I'm happy to give you here a little overview of the problem of checkpoint inhibitors after allograft transplants in the world of classical Hodgkin lymphoma. So we published several years ago in Blood a paper showing that this treatment is feasible after the checkpoint inhibition after allograft transplant in Hodgkin lymphoma, with a substantial risk of initiation of GVHD, so graft versus host disease. Many data have been published since that paper, especially a prospective trial by Dr. Davids, and showing that this risk is really important. And so probably this is not the best option to do the checkpoint inhibition after an allo transplant. Here I'm giving you a little overview of a recent commentary we published in Biology and Bone Marrow Transplantation, which is the kind of the opposite problematic. So when you have a patient with a Hodgkin lymphoma which is in remission with a checkpoint inhibition, should you go forward and try to consolidate this response with allograft or not? Trying to stay on checkpoint inhibition and hope for the best. So we comment a Spanish study published in Biology Bone Marrow Transplantation earlier this year, and which is giving good data to try to respond to this question, even though this is a retrospective study and this is not ending the debate. But yeah, I think the conclusion we can take in mind, like in a nutshell, this is doable. We can allograft a patient after checkpoint inhibition if we keep minimum, we would say 2 or 3 months between the last injection of checkpoint inhibition and the allotransplantation. And probably this is a good option to allograft patients when they are highly refractory with short response or partial responses.